Welcome and thank you to all of those listening. My name is Samantha Sattler, and I am a current fourth-year medical student at Albany Medical College. The topic of this talk is Kohlmeier Degos disease, particularly the necessity of multiple levels of advocacy in an ultra-rare diagnosis. I would like to thank Dr. Lee Shapiro, who is my mentor, as well as a leading expert on this disease and the basis for a lot of the information provided in this discussion. I would also like to thank the countless others who have dedicated their time and effort to research and advocacy regarding Kohlmeier Degos disease. To begin, I would like to say a bit about what Kohlmeier Degos disease is. This is an ultra-rare obliterative vasculopathy that presents in two forms. One is a benign cutaneous form, meaning it is restricted to the skin and presents with skin lesions, and the other is a potentially malignant systemic form, in which virtually any organ system can be involved. About 30% of the cutaneous Kohlmeier Degos develops into systemic Kohlmeier Degos, and the most common involvements include gastrointestinal and central nervous system disease. Other common involvements can include pleural, pericardial, and ophthalmic disease. It is important to note that without treatment, most patients with the systemic form will succumb to the disease within a few years, and the most common cause of death is often bowel perforation that leads to sepsis. Throughout this talk, I will discuss various levels of advocacy that are required in any rare disease, and specifically touch upon efforts that have been undertaken in regards to Kohlmeier Degos disease to demonstrate efforts that can be made, as well as to make listeners aware of resources that are available for Kohlmeier Degos. The first level of advocacy is awareness, which includes simply knowing that a diagnosis exists and being able to have it on a differential diagnosis. This is especially important in Kohlmeier Degos disease because cutaneous disease precedes systemic, and diagnosis is made via skin lesions, which can be biopsied for definitive pathologic diagnosis, but also recognized visually by the eye. The lesions are rather unique, and their differential quite limited. Just having recognition of this porcelain plaque with a surrounding erythematous rim goes a long way in terms of diagnosing Kohlmeier Degos. Here, you see a dermatoscopic image of what these lesions look like, with a central atrophic region surrounded by a rim of telangiectasia. This is especially important in Kohlmeier Degos disease because lesions are small in size, few in number, spare the face and hands, and are asymptomatic, meaning they are neither itchy nor painful. Therefore, without proper recognition, these lesions can be missed, dismissed, or even hidden for several years. Thus, making not only providers but also patients aware of what this means is very important. In order to do this, we have undertaken several advocacy efforts. The first is we have presented at multiple national specialty-specific conferences, including the American College of Rheumatology, Gastroenterology, and Dermatology meetings. In doing so, we have presented system-specific information for providers that are most likely to encounter Kohlmeier Degos. In addition, we have made efforts to inform the future generation of providers and have initiated a medical school curricula series that is being piloted at Albany Medical College and will hopefully be disseminated in various medical schools, since Kohlmeier Degos disease is not commonly discussed in medical schools currently. In addition, we have advocated to the editors of First Aid for the USMLE, which is a text used by virtually all medical students in preparation for the USMLE, or United States Medical Licensing Examinations. By having even a small section on Kohlmeier Degos disease, we hope that medical students will read about this and see images associated with it, so that if they ever encounter Kohlmeier Degos in the future, they will hopefully recognize and remember what this disease is and what it means for their patients. The next level of advocacy in a rare disease is workup. The average length of time between cutaneous to systemic onset in Kohlmeier Degos disease is about 1 year, so both patients and providers need to be aware of new symptom onset that may indicate internal disease. This is especially important in the case of gastrointestinal Kohlmeier Degos disease, as we have found that gastrointestinal symptoms almost always precede perforation, and therefore patients experiencing new or unusual abdominal pain, nausea, bowel habit changes, or any other gastrointestinal symptom need to know that this necessitates prompt presentation and workup. Again, this is very important as we have seen several cases that go all different ways. One is a patient who has these premonitory symptoms but does not realize that the symptoms are related to their Kohlmeier Degos disease, and therefore never present and may eventually perforate. Second is a patient with these symptoms who presents to a provider that does not realize that the symptoms are related to Kohlmeier Degos, and therefore does not initiate workup. Third is a patient who presents to a provider that realizes this may be indicative of internal Kohlmeier Degos disease and wants to initiate workup, but does not know the next best step to take. In this case, time and resources may be wasted in pursuing non-diagnostic workup. In Kohlmeier Degos disease, laparoscopy is the next best step, as this is the most sensitive and specific diagnostic technique to date. As seen in the images on the left, bowel lesions in Kohlmeier Degos disease occur on the serosal or outer surface of the bowel, rather than on the mucosal or inner surface of the bowel. What this means is that diagnostic measures such as endoscopy and colonoscopy, which evaluate only the mucosal surface of the bowel, might miss these serosal lesions. We have recognized that many false negative colonoscopies occur, and we realize that there is potential for false negative laparoscopies due to failure to recognize bowel lesions. Therefore, advocacy is necessary in order to inform providers on what to look for in terms of gastrointestinal Kohlmeier Degos disease. As you can see here in these images, bowel lesions resemble those of the skin. However, they may vary in size, number, and presence of an erythematous rim, which is more likely to occur on the skin than on the bowel. Prompt and proper recognition of these bowel lesions is necessary because, similar to what was said about the skin lesions, these bowel lesions are rather unique and have a limited differential diagnosis, perhaps including only peritoneal mesothelioma. In order to combat some of these barriers to recognition, we have created an instructional video on when and how to perform laparoscopy in Kohlmeier Degos disease, and what to look for and where to look for it. Another level of advocacy here is encouraging surgeons to bring a camera to the OR to photograph or video the procedure. The utility of this is multifold, as pictures and videos can be reviewed by others to provide diagnostic confirmation. In addition, it is important for informing the pattern of these lesions, and especially their potential response to therapy. This may allow us to develop a quantitative method for classifying and characterizing gastrointestinal Kohlmeier Degos disease, and perhaps its relation to skin disease. Advocating for the materials to do so is thus important from this research perspective. The next level of advocacy in a rare disease revolves around treatment. Advocacy for treatment is of major importance in Kohlmeier Degos disease, given that a 2-drug regimen has been developed for the treatment of gastrointestinal Kohlmeier Degos. This consists of eculizumab, a complement inhibitor, and treprostinil, a prostacyclin analog. Advocating for your patient to know that this treatment exists and to inform their provider of this takes a lot of effort and must be done swiftly. If lesions consistent with gastrointestinal Kohlmeier Degos disease are identified on the bowel serosa via laparoscopy, treatment with eculizumab needs to be initiated promptly. This is because eculizumab has an immediate onset of action and can prevent potential perforation. If perforation has already occurred, the efficacy of eculizumab is limited. In addition, adding treprostinil to the regimen is necessary to maintain remission and therefore achieve long-term coverage in this disease. Again, this is a rare disease being treated with a rare medication, so proper counseling is necessary in regards to educating on the existence of such therapies, their dosages, their administration, and the need for meningococcal vaccination prior to initiating eculizumab, given the complement inhibition. Another realm of advocacy in regards to treatment revolves around obtaining the treatment. This is especially true in Kohlmeier Degos disease for several reasons. The first is that these medications are off-label usages, meaning these medications are not FDA indicated for Kohlmeier Degos disease. This is because this is a rare disease, and no studies such as randomized controlled trials have been conducted to prove the efficacy of these treatments. This is a reality because we are limited in numbers of patients given the rarity of this disease, and we are also limited ethically speaking because we cannot subject one group of patients to inferior treatment when we have successful regimens in existence. Secondly, cost becomes an issue. Eculizumab particularly requires 1,200 milligram infusions biweekly indefinitely in patients with gastrointestinal Kohlmeier Degos disease. This surmounts to a cost of about $500,000 per year. Given the off-label usage and the tremendous cost, advocacy by the provider is very necessary and needs to be done promptly, as this can be the difference between life and death for a patient who cannot otherwise afford this drug on their own. Thirdly, insurance company or drug manufacturer education is sometimes necessary because insurance companies and drug manufacturers may not be aware of Kohlmeier Degos disease or their medication's treatment of it. Providers need to be willing to give education so that the insurance company might be more likely to provide coverage, or the drug manufacturer might be more likely to provide compassionate use of their medication. Fourthly, all of this needs to be done very urgently, and providers need to make sure that the insurance company and the drug manufacturer are aware of the urgency of this approval. This is because eculizumab's main role is in perforation prevention, and perforation can have any timeline, occurring in a few hours to anywhere as a few months or years. The urgency of these requests thus needs to be made known to all parties. Lastly, there is variable access based on insurance and country of residence. In international patients who have different systems of coverage and different approval processes, providers need to be willing to devote extra advocacy and be on top of making sure that these requests are seen through. In addition, when insurance coverage is changed for a patient, providers need to be aware of this change and willing to advocate to the new insurance company for coverage. This might happen during retirement or other life changes, and therefore patients need to make their providers aware, and providers need to be willing to advocate in such situations. In order to combat some of these barriers, we have drafted a letter to insurance companies to be used as a template in gaining access from insurance. We have also recently submitted a manuscript that outlines all of these points and can therefore be used as a resource or reference when communicating with insurance companies or drug manufacturers for medication coverage. The next level in advocacy in a rare disease revolves around future investigation. This is particularly important in Kohlmeier Degos disease because while gastrointestinal disease has the current treatment regimen as outlined on the previous slide, other systemic forms of the disease are not as definitively managed on this two-drug regimen. Central nervous system disease is particularly difficult, as finding a therapy that can cross the blood-brain barrier requires additional investigation. With any rare disease, gathering funding, support, and basic science researchers who are excited about the disease and willing to devote their time and investigation to it are important to finding targeted therapies. In terms of Kohlmeier Degos disease particularly, we have put active thought into this, and current investigation is underway. Dr. Shapiro meets with the National Institutes of Health monthly in a collaboration on Kohlmeier Degos disease. We send all of our patients there for workup, although not treatment, and while there, patients undergo various workup measures that provide us with information that allows us to evaluate genetic or other causes of this disease and therefore investigate targeted therapies. The last but perhaps most important level of advocacy occurs at the patient level in terms of providing hope regarding the diagnosis. Pessimism regarding prognosis, especially in Kohlmeier Degos disease, which is also termed malignant atrophic papulosis, is often perpetuated through the literature despite progressing therapies. This is because of limited conversation surrounding rare diseases in general and the percentage of old case reports or reviews that exist in so small a pool of published articles. What this means is a provider facing this diagnosis for the first time may perform a literature review and find older case reports with catastrophic outcomes. Or a patient newly diagnosed with Kohlmeier Degos disease may Google it and find either limited information or pessimistic information regarding prognosis. Ensuring that your patients are educated about this disease as best as possible and made aware that active investigation is underway is important to maintaining hope and making sure they are well informed. In terms of Kohlmeier Degos disease, we have provided this education regarding hope in various ways, including our most recent manuscript, various national presentations that have been given, and a newly developed patient brochure that is available on the Kohlmeier Degos disease website, which provides patient-specific information for those facing this new diagnosis. Thank you for listening. I hope that this presentation has provided necessary information on rare diseases, as well as Kohlmeier Degos disease in particular. Also, thank you to Dr. Lee Shapiro, as well as all of the other doctors and people who are investigating Kohlmeier Degos disease. In addition, a particular thank you to Kohlmeier Degos disease patients who share their stories and work to advocate for themselves as well as others tirelessly.